I'm Dr. Tim Babineau. I'm the President and Chief Executive Officer of Lifespan, and I'm the President of Rhode Island Hospital, and I want to thank everybody for coming out this morning to join us. As everybody knows, a very tragic accident occurred on Sunday during a circus performance at the Dunkin' Donuts Center here in Providence. On behalf of the entire Rhode Island Hospital community, I want to convey our ongoing and heartfelt concern for all of the patients and all of the families that we've been caring for. They, along with all of our patients, remain our very top priority, and we're so very grateful that at this time, none of the injuries appear to be life-threatening. In the medical community, we refer to the event that took place on Sunday as an MCI, or a mass casualty incident. Minutes after the event, Rhode Island Hospital received 9 patients, many of whom had obvious, significant, and complex injuries. Shortly after being notified of the incident and following protocols and procedures that have been practiced countless times over the years, our hospital's physicians, nurses, and staff prepared to receive the injured and then worked seamlessly to coordinate the complex care that ended up being required. Within 10 minutes of being notified of the accident, several operating rooms were opened and readied to receive the injured performers. As I mentioned, we cared for a total of 9 patients. 2 have since been discharged from the hospital. Today, we are still caring for 7 patients. 4 remain in serious condition, while 3 are in good condition. As the state's Level 1 trauma center, Rhode Island Hospital is always prepared for the type of accident that occurred on Sunday. At Lifespan and at Rhode Island Hospital, we are fond of saying that medicine is a team sport. And I can tell you that the team performed at the top of their game on Sunday. I am enormously proud of this institution and of our entire team of caregivers. In just 1 minute, I will ask some of the clinicians seated here that cared for our patients to speak about the extent of the performers' injuries, their care, and their prognosis. But before I do, I want to say just one brief word about these patients. We are the state's largest hospital, so it follows that in the course of a year, we meet many, many amazing people. But I can tell you that these patients, these performers, have been truly inspirational. Over the past couple of days, I have heard countless stories from our staff regarding the courage, the positive attitude, and the strong desire to get better quickly that has been demonstrated by these patients. They have truly inspired our staff and our physicians. They obviously love their work, and they are determined to heal as quickly as possible to get back to doing what they love. And I can assure you that we are doing everything in our power to help these remarkable young women reach that goal. It's now my great privilege to introduce just a sampling of the caregivers that have taken care of these patients. They represent dozens and dozens and dozens of our team that have been involved in the care over the past couple of days. Each of our caregivers that I'll introduce in turn has prepared a very brief statement, and then I will field questions after that. I need to reinforce that while our staff will be able to answer questions about the event and the extent of the injuries, treatment, and prognosis in general, we will not speak specifically about any patient out of respect for their privacy. And I know that you will respect that privacy as well. It's now my pleasure to introduce the person sitting right next to me, Dr. David Harrington, one of our trauma surgeons who was involved in the care that day. You want to just do it there?
Thank you. So I was the trauma surgeon on call that evening, or that day, and I do want to make a comment that I'm here kind of representing my team, but I will except we just brought into this little hard deal, that's all we did.
Next is Stephanie Farquhar, who runs our trauma intensive care unit and surgical intensive care unit. Stephanie?
All right, well, thank you. As Dr. Harrington mentioned, I was notified Sunday afternoon by the nursing staff on the trauma intensive care unit that we had been asked to implement our mass casualty plan. At that point in time, staff were working with Dr. Harrington, his colleague, Dr. Mike Connolly, to triage the patients that were in the intensive care units, that we would have the capacity to accommodate any patients that we were going to see as a result of this accident. The initial reports were between 6 and 11 patients we had heard. Some were between 5 and 15. And for the nursing staff on the trauma intensive care unit, the extent of their injuries and what we were going to be caring for was largely unknown at that time. So in addition to needing to maintain our capacity to take care of the influx of patients we were going to see, as Dr. Harrington alluded to, we also needed to maintain our capacity to care for any other member of our community that was going to require the care of the trauma services during this time. So all of the ICUs in the organization and several units went through a similar process where they implemented their mass casualty plan and worked with their teams to manage the patients on their units so that we could have the maximum capacity available for us, for anyone who came through the door. From this point, we worked in the trauma intensive care unit on mobilizing personnel. We placed multiple nursing staff on call throughout the day on Sunday and into Monday so that we'd be prepared to take take care of any patient that was coming in regardless of their injury. And from here, truly, the intensive care unit was in a wait and listen mode. We were waiting to hear from our colleagues in the operating room the number of patients we'd be receiving and the extent of injuries that we would be caring for. By the end of the day on Sunday, going into Monday, the intensive care unit had received 5 of the patients from this accident, which again, to echo Dr. Harrington's sentiments, truly is not an unusual number of patients to influx into the unit. Certainly the circumstances around their injuries were unusual, but we were able to accommodate the patients and maintain care for them and all the other trauma patients in the community during this time. The team is continuing to work with the patients diligently, and we are wishing them a speedy recovery, and we are incredibly proud of the team and how they rose to the occasion on Sunday.
Great, Stephanie. As you can tell, it is a team sport, and Stephanie's a critical member of our team. Next, you'll hear from Dr. Arthur Burt, who is our Chief and Chairman of Anesthesia, who was really one of the folks orchestrating the ballet of the different operating rooms and different triage protocols on Sunday. Dr. Burt?
As Dr. Harrington remarked, we do this all the time. We are prepared for tragedies like this, so that while it was a little bit more than our usual Sunday emergency work, we have procedures and protocols in place that were utilized. So within about 10 minutes from David's phone call to the operating room, my in-house staff, so we would always, as a level 1 trauma center, we are always running the operating rooms on Saturdays and Sundays. We have a different mission than other hospitals, and my staff, very talented nurse anesthetists and anesthesiologists, understand it. So they spend much of their Saturdays and Sundays here taking care. And in fact, that day we were already doing life-saving surgery for a patient who needed heart surgery, patient who needed general surgery, when this additional tragedy occurred. We mobilized our team. I always need to stay ahead of the surgeons in terms of my ability to run more than anticipated operating rooms. And I got to tell you, in addition to everybody who would have normally responded, I had phone calls the minute this hit the news from all of my staff volunteering to come in and staff. Trauma surgery is in fact absolutely a team sport, and we work in teams. These are complex surgeries. Many of these patients needed multiple surgeries in the same operating room setting to minimize the time they were under anesthesia, to maximize the potential treatment of their surgeries. As you're going to hear from the next 2 gentlemen, we had multiple different surgical specialties working, and I need multiple anesthesia personnel on each patient. So we have teams of nurse anesthetists and anesthesiologists, which I believe is the absolute premier way to care for people, working together to airway management, invasive monitoring, manipulating appropriately the physiology of these critically ill patients, blood transfusion. All of these things require multiple hands. And I'm proud to say we rose to the occasion. You know, I was here Sunday about over 12 hours. I got home when we finished our last surgery about 12:30 in the morning, and my wife, who obviously lives with this lifestyle of mine, said, "Oh, you must be exhausted." And I honestly turned and I said, "I'm not exhausted at all. I've never been so proud of being part of this wonderful organization we call Lifespan."
Great. Dr. Burke, thank you so much. Next, you'll hear from Dr. Oliesi, one of our neurosurgeons. Dr. Oliesi?
So I second everything that's been said about the way the hospital responded to this event on Sunday. I was actually already in the hospital for a different reason and got a call from one of my residents who said we had multiple patients that would need urgent spine surgery in the emergency department. So I placed a call to the operating room, and the nurse coordinator, Robin Nolan, that day said, you know, we'll be able to run multiple rooms at the same time. We had 8 patients that we evaluated for spinal fractures that day. Of those, 5 had non-life-threatening or non-critical fractures that we were able to either observe or manage conservatively with a brace. 3 of those patients, however, had critical spinal fractures, and of those, 2 also had significant injuries to their spinal cord. So I placed a call to my acting chairman, Dr. Doberstein, and we decided emergently to take 2 of these patients to the operating room, operated on them simultaneously to stabilize the spine and to try to limit the extent of the spinal cord injury. So all in all, the patients with the critical spinal cord injuries we've seen show some mild improvement. We're hopeful that they can make some sort of a recovery, but only time will tell. And again, I would say, this is what we do as a level 1 trauma center, and I'm proud to be a part of this.
Dr. Eliossi, thank you very much. And last is Dr. Roman Haida, one of our orthopedic trauma surgeons. Dr. Haida?
I'd like to emphasize a point that Dr. Babineau mentioned at the start. The spirit and the engagement of the patients and their families is nothing but incredible. Coming from all parts of the world, and that undoubtedly will be critical in their overall recovery. And I'm proud to be able to assist them in that process. So just to kind of backtrack a little bit to tell you what the orthopedic team did, I'd like to emphasize the actions of our house staff that were critical in those first phases when you have a number of patients, all kinds of extremity injuries, spine injuries, and so forth that require very accurate evaluation and stabilization. All in all, there were 7 patients that had significant extremity injuries in addition to the spine fractures that were mentioned, in addition to the abdominal and chest injuries that occurred. And we have to work as a team to figure out what are the priorities, how to initially stabilize, and how to finally get them to the path of recovery. So the house staff did a lot of this evaluation in concert with the attendings. We prioritized the list. I was on my way back home from New Jersey when I got this call, and a number of us came in to facilitate this evaluation and prioritization. So we met as a team. We called in extra residents and so forth to create a plan right at the start. And we prioritized the open fractures. There were 5 patients that had open fractures and a number of significant extremity injuries in addition to the other injuries already mentioned. So at this point, our first priority was to clean up and stabilize the open fractures, which was done on the day of injury. And then as the patient condition allowed, we did definitive fixation of their fractures, some of which happened on Sunday, many of which occurred on Monday and Tuesday, or yesterday. As far as I know, there's still 1 patient awaiting definitive treatment of their fractures because the complexity and the swelling around the extremity, the safest thing to do is to wait a while. She's stabilized, but she has not had her definitive fixation. But all of these patients are being evaluated, reevaluated, and treated, and we're working very hard at their recovery, and I'm sure that their spirit that we mentioned, their fitness, their youth, and the help of all the team is really what's going to make them go a long way. Now, I don't know if all of them are going to be able to be acrobats. That's an extremely demanding job. I know I couldn't do it, even in the best of health, and our goal is to get them there, and that's what we're working on.
Dr. Haida, thank you. Just a couple of additional points, and then I'll open it to questions. Picking up on the patient story, there was one story where one of the injured performers was in some pain, but didn't want to take their pain medicine because they didn't want to get out of sync with their stretching routine. So they were already thinking about their recovery, even though they were having some discomfort. Secondly, this was a Sunday, and we were more than adequately staffed for a typical Sunday. This was anything but a typical Sunday. A lot of people came in on their day off. A lot of people volunteered to come in. We're not on the schedule to work. This is the team, this is the family that defines Rhode Island Hospital. And despite having a Sunday afternoon plan with their family, everybody dropped what they were doing at a moment's notice and came in. Although the folks at the table are primarily involved with the operative intervention and the operative care of these patients, Much of the care started in our emergency department, and there were many caregivers in our emergency rooms who are here with us today who did the initial triage, the initial care of the patient, pharmacists, lab technicians, respiratory therapists, transporters. It is a team sport, and I'll tell you right now, this is one of the best teams in the country. I'm now happy to answer questions. If you wouldn't mind, direct them to me, and then I'll try to triage them to the appropriate expert. Yes?
Are any of them paralyzed?
Dr. Oliesi, the question about long-term prognosis for the spinal cord injuries?
So as I mentioned, there were 2 patients that had critical spinal cord injuries, and they're varying grades of spinal cord injuries. We don't know ultimately what the long-term prognosis is going to be, and we won't know for some time. However, what I can say is that the injuries in at least 2 of the patients was significant enough that they were not moving their legs when they first came in to varying degrees. There has been a little bit of improvement in 1 or 2 of those patients, but we won't know what the ultimate recovery would be for probably close to a year.
Great, thank you. Next, yes?
For the patients, maybe those 2 who were discharged, talking about getting back to performing is clearly a focus for these women. For those who are doing the best, when might that be?
Dr. Haida, the folks we discharge, when can they get back to full activity, knowing that full activity is hanging from a trapeze?
As long as I'm not hanging, it's okay. I believe that one of them had a spine fracture that was stable, and so that needs time for recovery. I think it'll be a matter of months. It'll be, but I don't know all the details of that injury because I didn't do the evaluation. But in general, I think those that have been discharged already, they have an excellent prognosis, but it'll still take a number of months to recover to the degree they need to be able to perform.
Yes, sir.
Doctor, I don't know if it would be Dr. Harrington answer or maybe yourself, but these patients are spinal fractures, probably orthopedic fractures of the knees and legs. How difficult was that to go after all at once? I mean, you got multiple injuries. How difficult, maybe Dr. Harrington, how difficult was that? How do you prioritize spinal fracture versus maybe a deep bone fracture?
Yeah, the first half an hour or 15 minutes, half an hour are very difficult because you want to think about priorities of that things that threaten life and then limb. So, for instance, of the patients we had one person who had a true life-threatening emergency because she had a major abdominal injury and a major liver laceration, and that could quickly claim her life. So, and we have protocols, and it gets to that point about we do this every day. We triage people based on level of severity. So she got quickly brought to the operating room. I mentioned Mike Conley doing that. The next thing is limb. And so limb would be this idea of, we had a couple of fractures that Dr. Heide's team managed that were so severe that the blood supply to the distal part of the limb was compromised. And they needed to be immediately fixated and brought out to length. So that was a life-threatening or limb-threatening problem. And then the next part was this idea of decompressing the spine. It doesn't have to be done in the first 5 minutes, but the quicker you get those bone fragments off that contused, bruised, edematous spine, the better. So we prioritize it. It's a very standard thing we do here. This is what we do.
Other question? Yes, sir.
Long term, since it happened, there was one clip I read, it was not about this at all, but about fall injuries generally. And it was sad to read that the writer said, that the doctors have said that sometimes you go the whole rest of your life and you'll never really be where you were at 10 o'clock on Sunday morning as against 11 o'clock.
Sure. Dr. Haida, fall injuries in general, severe injuries from fall?
Well, it's remarkable how relatively, it could have been much worse. From a fall of 30 or 40 feet, actually is accompanied with a significant mortality rate, and I think we're beyond the period that any of these folks are going to die. So that's number one. And my understanding is they landed on a fairly hard surface, but I don't know the details on that. Padding over whatever surface they have at the Duncan Center. Now, the long-term recovery, is anybody ever the same after some of these injuries? Certainly, I think the spinal cord injuries, that remains to be seen. Will they return to functional activity? It depends on what the degree of spinal cord recovery is. In terms of the extremity injuries, the ones that are easier to recover from and really have minimal or no sequelae are the fractures of the long bones, and there are a number of those. The ones that are harder to recover, particularly for this patient population, fractures into joints that really damage the articular surface, can lead to stiffness and weakness and even arthritis. Now, even if that is there, some people recover remarkable activity, people with arthritis. Where will these people end up is still unknown, but given what I've seen, I think they'll go far. They will, I'm sure, recover very meaningful lives, but whether they can perform, do handstands and things like that, we're working on that.
Thank you, Dr. Hardy. Yes,
Did any of these people have compartmental syndrome, and could they ultimately lose a limb?
Dr. Hyder.
No one had compartment syndrome. The rapid reduction in stabilization helps limit that, and so there were no injuries like that, although there were open injuries, and there's certainly no amputations in this group.
I think it's fair to say that part of the reason that overall we have a pretty good prognosis for all of the injured patients had to do with the fact that there is a level 1 trauma center in this state. It happens to be located in the city where the accident occurred, and the time between the injury and the time when they received treatment, I think that's called the golden hour, David, if I remember from my days, was very brief. That has mattered a lot in how well these performers have recovered. Someone, yes?
Are the women who are still in the hospital, can any of them walk on their own, and how much assistance do you need?
Dr. Alessi, of the 7 people we have with us, how many are walking?
So a lot of them also had orthopedic injuries, fractures to the limbs, fractures to the legs that may preclude them from walking. The 2 that I would be concerned about would be the 2 that had spinal cord injuries. Those, I think, as I mentioned earlier, only time will tell what sort of ambulatory function they're going to regain. For the patients with orthopedic injuries, I presume, as Dr. Hyder said, when those heal, they should be able to recover ambulatory function.
I'm being asked, Dr. West, to pull the microphone a little closer to you, if you don't mind. Okay. Sorry about that.
Correct.
Yep. Yes, front row.
Could you talk a little bit about the one patient who had the fracture that had to be waiting to be treated, and also how much pain the women are experiencing right now?
I'm not sure I understand. Ask the question again.
There were 2 parts. The first was about the fracture that needed some time before it could be addressed, and the second is just in general how much pain.
Yeah, I don't think any of the fractures waited to be addressed, so I just want to clarify that. I think you had mentioned some of the spinal fractures.
One
you had to
had
get
one
to.
patient that he mentioned.
Yeah, so I can clarify. So there was a patient that has a specific injury into a joint that's a very complex injury. She was stabilized. She actually is in what is called an external fixator that holds it stable and splinted. But you have to wait, because if you operate early, because this is in a very sensitive area, you can have problems with wound healing, and then you have an infection and so forth. So it's routine for these fractures to be temporarily stabilized, and then in a week's time, sometimes 2 weeks' time, you come back and do the complex surgery to reassemble the joint.
And Stephanie, you want to speak a little bit to our pain management protocols and how we balance pain management with making sure we get folks up and out of bed?
Sure. So as all of my physician colleagues have mentioned, these girls have suffered significant injuries, so there is still a significant amount of pain management that needs to occur for them. Right now we're trying to strike the balance of managing their pain in a way that will allow them to begin the activities that they can to begin to rehab from their injuries. So they certainly have a long road ahead of them, and we are working with them and our physician colleagues to manage their pain as aggressively as we can without hindering during their recovery.
Thank you. Yes, sir.
Yes, 3 days in, I wonder if someone could generalize for me the degree to which you think these patients, well, here's another way to ask that. You guys go to bed at night, what are you worried about on their behalf? Which concerns are rising to the level of maybe keeping you up, or at least you're thinking about it just as you're falling asleep? Like, wow, I hope that works itself out, or this or that, or is there something, do you get where I'm going with this?
Yes. David?
I think if you've been in the business of taking care of critically ill patients, after a while you sleep well.
Because you're good at it.
Because you do your job up front well. And so if you spend too much time worrying about it, you don't have a very long career because it'll chew you up. So the things I worry about, the things that scare me, for that first hour, patients who lose their airway, people who have severe head injuries, people who are exsanguinated from bleeding. Those are things that still scare me to this day. Everything else is manageable. The good news about this accident, if you can want a silver lining, is that luckily none of these women had severe head injuries, which was really a blessing because those are very difficult to recover from. And the people that had, despite falling from 25 feet, who had major injuries to the liver or spleen was only one. So the things that really would make me worried as a trauma surgeon didn't happen or were quickly addressed.
Thank you, David. Yes, miss.
How long do you expect them to be here at Rhode Island Hospital?
That's a good question. I'll ask Dr. Elias and Dr. Hyder to address anticipated lengths of stay. I know that's always a tough question. Yeah.
Sure. So it's a little difficult to say with the spinal cord injured patients. From our perspective, there are a number of things that we do when they come in. The first thing when they hit the emergency room is we try to stabilize them medically, get the blood pressure up to the spinal cord, get them to the operating room emergently, decompress the spinal cord and stabilize it as necessary. That requires some time to recover from in the hospital, in the acute setting. We also continue to keep their blood pressure up to continue to perfuse the spinal cord for about a week, and that's why 2 of those patients are still in the intensive care unit now. So we know they will be with us for at least a week. There will be some further time needed for them to recover from the surgery, and then we'll be looking to get them to an acute rehab facility where they may well be there for another month or 2. So it's a little difficult to specify. It's very patient specific in the short run how much time they will be here, but we know they will be with us here for at least a week.
Dr. Hyder, how about the patients with orthopedic injuries?
Yes, so some of these patients have combined orthopedic and spine injuries. Those that have just orthopedic injury, extremity injuries, those that have completed their surgery, which is all but one at this point, we're just monitoring the wounds, starting to get them mobilized and so forth. So in a matter of days, we could make arrangements for continued rehab. The one patient I mentioned that will need further surgery, we're already planning that, and that'll occur probably next week, and then discharge after that. But I anticipate that these folks will need physical therapy rehabilitation for a number of weeks. It'll take their fractures anywhere between 2 months and 4 months to be healed, but their overall recovery, these are severe injuries, their overall recovery will be on the order of months. And that's one thing that's really important to remember, and they'll need the help of their families and so forth. I'm told that the girls want to go to rehab together. I'm not sure if that's true or not, but that's what I was told, and that certainly would be a great team building and motivational activity.
Got time for 2 more questions. Yes.
Down the road, do you anticipate marshaling any social services, counseling? I mean, they've lost temporarily, at least maybe forever. We don't know their livelihoods. They might be here from overseas and not speak the language well enough. How are you dealing with those issues?
Right. So I had the pleasure of meeting Mr. Feld and his daughter on the first day, and obviously their utmost concern was for the recovery of their performers, and we had a conversation about making sure that when those needs arise, we coordinate what we can do and what they plan to do for their performers. But I can tell you that in the brief conversation I had with him and his daughter and with Dr. Murphy, my chief medical officer, it was evident that they knew these girls were going to require services much beyond the stay here, and they were absolutely committed to making sure whatever they needed was provided.
It's also addressed the resiliency of the human body and the human spirit in the totality of the circumstances. It seems to me I'm getting a theme that it's very much in play.
Arthur Bill.
I'll make this comment. One of the things we were able to do that I think will help their recovery was recognize these were the equivalent of world-class athletes. So after we addressed their most critical life-threatening problem, my anesthesia staff felt we could keep them stable based on how healthy they started the day and allow their open fractures to be addressed immediately to improve their chance of not getting an infection, not losing more blood, and that's critical to their overall recovery. We were able to do that because they were so healthy to start with, and we felt that would be the best way. The other reason, and again I thank my colleagues, if a young lady had multiple extremities injured, and many did, we were able to work on both of them simultaneously because we had enough orthopedic surgeons willing to do that, and that minimized the trauma to their body in terms of the time under general anesthesia and overall blood loss. But that is, I would agree. The other thing I want to, the question you asked earlier, I will tell you one of the things from anesthesia, we don't usually get to make long-term relationships with patients. You hopefully only come from one surgery that you planned. But obviously these women are coming back for multiple surgeries. And one of the things I do worry about at night is that they understand we see each of them as a unique individual. We recognize their fighting spirit. We know their names. When they come down each time, now accompanied by their family members, we let their family members be with them. And we recognize who they are and, don't make them go through the history taking. We know who they are, and we just want to respond. How was your last trip down? What can I do different? What can I do this time to make it better? We want them to know we recognize the great strength they're showing. We want to mirror that with our care and empathy.
Last question.
So the Circus has moved on to Hartford. They're not going to continue with this hair hanging stunt in Hartford. But do you think, after you've seen the injuries that these young women have, should people be hanging from their hair in an aerialist stunt, or is this meant to be dangerous?
I'll take that. I'm going to let my colleagues off the hook, and I'm going to defer that question to the Feld Entertainment Company. The last comment I would make, and then we will make these folks available individually for Q&A, is today we've been talking about 7 very special patients that we've been taking care of. At any given time, Rhode Island Hospital has 600 patients in it, and we're taking just as good care of the other 593 that we didn't talk about today. These 7 are very special to us, but we provide this level of care to everybody who's in our beds any day. Thank you for coming. We'll make them available for some individual questions. Thank you very much.